All right, well, welcome everyone. I'm going to start the recording here briefly and then switch over to the proper screen for our cases. Got to stop the share and share a different screen. All right, can you all see the slides?
Yes.
Okay. Now you'll have to bear with me. I'm using a new laptop this morning, so I'm not quite as good with the focus as I would like to be, but we'll adapt to that.
Yes.
So this first case that we'll talk about today is a middle-aged woman who had an ovarian mass. Now, you know, I like a lot of ovarian things, so this was an easy choice. But this is a frozen section slide. Now, of course, in pathology, we want to always provide an accurate diagnosis, but in frozen section pathology, of course, our objective is to guide the surgeon to be able to make the next appropriate step. And that oftentimes in gynecologic surgery means, do they stage the patient? Do they do more biopsies to stage, or do they do other sorts of things, or none at all? And so this was such a case where our objective was to tell the surgeon enough information so that they would know what to do next. At low magnification, this is where we get a lot of our information, because we know that with frozen section, there's going to be a lot of artifact that will change the cytology and so forth. And what we see here is we see a variety of open spaces and variable sizes of these spaces. And so this is something to think about, the kinds of tumors that give you those kind of open spaces. And we also see maybe some inflammation and a little bit of fibrous tissue, and then more cellular areas here. So we'll go down a little bit on this area, more cellular area. And I think you can see now that these are quite eosinophilic cells, a lot of eosinophilic cytoplasm lining these open spaces, which we might refer to as follicle-like spaces. And the nuclei are really quite round. You can see they're really quite uniformly round and fairly even. So even though our cytology with frozen section is not optimal, we get the sense of a very low-grade appearance to the nuclei. Then many of these follicle spaces or cystic spaces have some sort of eosinophilic material in them. And as we look around, we can see some of them are very open, but others have more of this material in them. And so the challenge with this, of course, is to remember to think about it. Because if I told you that this was a head and neck surgeon and they had sent the thyroid, you would say, oh, well, this is, you know, normal follicular thyroid epithelium. Maybe it's got some oncocytic change. But in the ovary, we don't always think about thyroid epithelium. And so when we get a pure stroma ovarii, which is what this is, we sometimes have to think a little bit to remember that this does occur as a so-called monodermal teratoma in the ovary. And of course, this is a completely benign lesion. The only concerns are if it's associated with some other elements of teratoma that may be immature, which your sampling should hopefully be able to exclude, or on very rare occasions, these stroma ovarii can develop the neoplasms that we see in the native thyroid. And so we can see papillary carcinomas, or even occasionally undifferentiated carcinomas or poorly differentiated carcinomas that arise from a stroma ovary. So those are the learning points, I think, from this particular case, is just to remember to think about that possibility, and you should be good. Now, as usual, if you have questions, don't hesitate to type them into the chat box. I'll try to pay attention to those as we go along and answer them. All right, well, let's go on to the next case. This is a nasal mass in a middle-aged individual. And it's a little bit unusual that they would send this for frozen section, except I think that they wanted a little bit of the direction in terms of what additional workup needed to be done with the sample. So sometimes that's the question we're being asked, is to triage the sample to know whether to send it for cytogenetics or to send it for flow cytometry or something of that sort. And so this nasal mass, I think, prompted that kind of consideration. Is this a lymphoma, plasmacytoma, or something like that that could benefit from the further evaluation by additional ancillary testing. So again, at low magnification, we see a little bit of heterogeneity, variable blue areas and more pale areas. Now this is, as you can see, the stain here is a little different than the earlier slide. And that's a consideration also, in that sometimes, because frozen section staining procedures are not always standardized, that sometimes you'll get variations in staining character from day to day, or certainly from location to location. But this is a much more blue stain than an eosinophilic stain. So we either didn't spend as much time in the eosin, or there just isn't as much eosin in this particular case. And as we look at the low magnification here, we see there's kind of a packeting of these cells. They're in nests, rounded nests, and variable size, almost like they're sort of forming little bags of marbles, if you will. And the cells are quite small blue cells, you might say. And as we come into higher magnification, I think you can see that there's a degree of variability that's fairly striking between the nuclear size and shape. So this does not look like a lymphoma. And so we answered that question for our surgeon. We were able to say, you know, this looks not like a lymphoma. We don't need to send for flow cytometry. But in the sinonasal tract, there are a couple of things that would have this in the differential. So the first thing to consider, of course, is neuroblastoma, which certainly occurs in this location and can have a small blue cell appearance. Things that we might think of that would help us with that are areas like this, where you sort of have a little bit of neuropil type of structure being formed, and that may suggest neuroblastoma. But we'd also have to consider things like sinonasal undifferentiated carcinoma, some poorly differentiated neuroendocrine tumors, and other sorts of lesions of that sort in the differential. And so providing on frozen section an answer like, small blue cell tumor, favor neuroblastoma, or small blue cell tumor, not otherwise specified, await permanence or something like that, would be an acceptable answer to tell the surgeon that you have diagnostic material. We're going to need some additional workup to fully subclassify it. And we're heading down this pathway of evaluation rather than down a different one. I suppose the other thing in the differential I always want to think about is melanoma. There can be small cell melanomas that can present in the sinonasal tract as well. And so being aware of that possibility is important as well in this sort of a situation. So those are two frozen section situations that are not uncommon, and the kind of questions that we're being asked are quite pertinent. With the next case, we illustrate another situation where frozen section comes into play, and that is in the evaluation of margins. So this sample, as you can see, it's from a soft tissue. We have some skeletal muscle here, and then we have this sort of pale staining infiltrative pattern of tumor that we can see here. So here we're being asked to say, is the tumor at the margin? And therefore, do I need to do more surgery at this margin, or do something further? Consider that as a possible, what I might additionally be able to do. So one of the techniques that we have in evaluating margins is to use an ink that will be visible on the glass slide. And in general, we use India ink. Now, India ink is a little bit tricky because it's liquid, it flows and so forth. And so if you just put India ink on the specimen, it will flow into every crack and crevice. As you see, it's done here. This may be the surface out here, but it's gotten down into here and so forth. And that then, of course, makes the evaluation of the margin more difficult for us. We are imprecise in that sense. So what do we do to sort of combat that? Well, one is the way that we apply the ink to the specimen. So you could just, dip the specimen into a liquid solution of India ink, and it would be all over the place. That would accentuate this problem of ink where you don't want it. So in general, we use a technique of either using a swab or a piece of gauze to sort of paint the surface or blot the surface with the ink, so that it's getting contact with the surface, but it's not being contacted with an excess of liquid. The second thing which we do as we apply ink to the surface is that we will then use what would be termed a mordant or a coagulant type of reaction that helps to fix the ink to a slight degree on the surface, so that it doesn't run, and so that it can you can use it, without having to wait for a long time for it to dry, for example. These are very easy to use, and the most commonly used one is common household vinegar or acetic acid. That's readily available in all parts of the world, and it is quite effective. So sort of coming back to our case here, I think we would, in most cases, indicate to the surgeon that this margin is positive. It's certainly close enough here that within the realm of uncertainty, the surgeons should consider that that margin is going to be a likely source for recurrence. And of course, the types of tumors can make a difference as well. So this is a tumor, and in this case, we probably had the benefit of knowing beforehand what the tumor was because they probably biopsied it. So we don't really have so much to make the diagnosis on frozen section, which might be rather difficult. We can see that there's sort of a spindle and stellate pattern of cells. There's a moderate degree of atypia through this. But aside from saying that this is a, likely sarcoma, we would have a difficult time on frozen section fully classifying it. But this was known previously to be an undifferentiated pleomorphic sarcoma. And of course, those tumors do have this propensity to grow along fibrous septae, which you can see here as it grows along this fibrous septae. It infiltrates in the skeletal muscle in areas. And this very insidious pattern of growth in this tumor makes it exceptionally difficult for the surgeon to be able to tell what is tumor and what is not. And even for us sometimes, if you go down on a high power area like this, well, this just may be some inflammatory changes in some stroma. So it's not always really easy to tell what we're dealing with in terms of margin, but seeing the seeing the contiguity between this area and the other areas of the tumor would help us to be convinced that at least this area is positive. Other areas like out here might be more difficult to state with certainty that this is tumor, although here I think we would also probably call this tumor at the margin here. Now I'll mention one other thing about ink, and that is that there are colored India ink solutions that can be used to discriminate one area of the margin from another area of the margin. And in this particular area, rather than using a black India ink, we have used a yellow or orange color India ink that says that this is a different aspect of the tumor than the black area on the other side of this specimen. And that's very useful for a variety of specimen types, both small skin excisions as well as breast excisions on occasion and other soft tissue excisional surfaces. For example, we also use it in the pancreas. We'll ink the bile duct yellow. We'll ink the pancreatic margin blue, and we'll ink the uncinate or retroperitoneal margin black, sort of as kind of a routine to enable us to standardize our use of the inks and to communicate very quickly which margin we're looking at. So those are some comments on evaluating margins at frozen section and on the use of various India inks. Okay, well, let's step away from frozen section for just a minute or two and talk about some of the things that can mimic disease or mimic dysplasia. This is a cervical cone biopsy. And as we look at this, we might say, well, I'm very concerned about this area, all the blue here. This looks like it could be maybe invasive neoplasia, or either invasive neoplasia or in situ neoplasia. And so we'll come down on higher magnification here. And what we see are a number of endocervical glands. And we see some squamous epithelium here that's a little bit on the blue side, but it seems to have some maturation to it. As you see here, it's fairly complex in here. And we're getting quite a bit of inflammation as well. And here we've got what looks like considerable glandular complexity, a lot of this microvesicular change, along with this inflammatory change in the lumina. Looking around a little bit further, again, we see this, this area is not in focus particularly well. We see this squamous type material with some degree of maturation, somewhat surrounding or underlying some of these endocervical glands. We'll look at one of the other fragments here as well. So we didn't see anything in that really looked too much like dysplasia or high-grade SIL. We'll look at this area here. And again, the pattern here starts to look fairly similar. We've got glands and we have this metaplastic type of epithelium surrounding some of these glands. Now, when I was training, this was sometimes called reserve cell hyperplasia. It's essentially just early squamous metaplasia. But it can be concerning for dysplasia or high-grade SIL for the novice and even at times for the experienced pathologist. So it's not out of the question to maybe do a P16 stain on this if you're really concerned. It will usually be negative in these situations and help you to feel reassured that you're not dealing with a high-grade lesion where the HPV DNA has been incorporated. Now, the other change that we see here in the glandular epithelium, as we see right here, is sort of what we saw in that earlier area. This is what might be termed microglandular hyperplasia, where you get small glandular spaces and a lot of vacuolization in the endocervical glands, along with some active inflammation. Again, this was early on was a mimic of endocervical adenocarcinoma. We now recognize it as being a probably a hormonal related physiologic change. Here at low magnification, probably this area right here is what we would term microglandular hyperplasia. Now, there are many better examples of this, but this had both of these lesions together. And so I wanted to sort of do this as a two-for-one type of exchange. Now, it's important that you get enough breadth of experience as you're learning and as you're growing to be able to recognize these variants of normal and the mimics of neoplasia or dysplasia. And so seeing a lot of slides, evaluating a lot of different cases is helpful to provide that breadth of experience and to know when to call it dysplasia, when to not, and when to stain in these circumstances. I think in this particular situation, I probably would not do a P16 stain because I'm reasonably comfortable that all of the squamous elements here are metaplastic or immature metaplastic in this situation. All right, well, let's go on to another case. Here is an endometrial biopsy. And at low magnification, we can see that this is not normal endometrium. We have a lot of sort of solid and bluish material. We see a little bit of architectural variation. So in an older patient, as in this case, seeing a solid proliferation like this at low magnifications should immediately make us start thinking about the higher grade endometrial carcinomas. And that would include serous carcinoma or endometrioid grade 3, or possibly carcinosarcoma. In general, endometrioid lesions tend to have rounded glands and have more open spaces as low-grade tumors. But as they become higher grade, the glands are collapsed, there's more solid tissue. And so it can be difficult to distinguish the difference. And so glands like these right here, this could be a high-grade endometrioid lesion, or it could be possibly a serous carcinoma. It doesn't have the characteristic micropapillary or slit-like spaces that we sometimes associate with serous, except right in this area here. So there's a little bit of that little papillarity and some sort of slit-like spaces there. But these tall columnar cells could easily be endometrioid type tissue. And that's where the value of p53 staining comes, is to do the p53 stain in these situations to help you classify it further. Now, the other somewhat interesting finding here in this situation is, as you see here, these cells between the glands look different. You see there's a lot of cytoplasm to these cells. And you might be thinking, well, is this a sarcomatous component of this tumor? Do we have a mesenchymal transformation? But at least in the United States, many times when patients begin to experience postmenopausal bleeding, the surgeons will, or the gynecologist will prescribe some progestins to help staunch the bleeding until they can get the patient in for a biopsy. And that, in fact, is what was done here. The patient was given some progestins, and the stroma that still remains has become decidualized. And so this is a reaction to the gynecologist's prescription and not part of the tumor. But it's kind of an interesting contrast here. So let's look at some other areas of this lesion and see if we can get a better idea as to what we're looking at. Here, I think maybe we would begin to lean more towards serous carcinoma. First off, we see the very high-grade nuclear features, and we're seeing more of these slit-like spaces and disoriented jumbling of nuclei. They're not quite as tall and columnar as in that other area. Here you see it, a lot of micropapillary changes off the surface. And again, a little bit of that decidual reaction in the stroma. I'll look at the other fragment here and see how this helps us. So here again, we have sort of a combination. We have these more tall columnar cells here in this particular fragment, high-grade mitoses, high-grade nuclear atypia. And then over here, almost cribriform areas. And then more of our micropapillary changes. So I think by and large, I would favor the likelihood that this is serous carcinoma based on the presence of those very high-grade nuclei and the micropapillary structures. Here you see a little bit of it there on that surface nicely. But recognizing that some of these tall columnar glands could be seen in endometrioid type of adenocarcinomas. And of course, we would do the p53 stain. Now, it was pointed out to me recently that because of the challenges in interpreting p53 stains, accompanying a p53 stain with a p16 stain is oftentimes a very helpful tool, particularly in the cases where you may have the so-called null type expression of p53. So as you know, there are several types of mutations that can be manifest differently in p53 staining. And so the null type of pattern, where you have no cells positive in your tumor, can be easily missed or misinterpreted if you have a few scattered stromal cells and otherwise that are lighting up. And that's where the P16 can be very helpful. If the P16 is diffusely and strongly positive, that's an indication that you have a mutation going on in the cells, and likely in this case is not an HPV related mutation. It's a P53 TP53 mutation that likewise highlights and accentuates the expression of P16. So that's a little bit of a clue to avoid the pitfall of falsely undercalling a null type P53 stain. All right, let's move on a little bit further. This is quite an unusual specimen in the sense that it's not something we usually get. This patient was being treated for, I believe, for breast cancer, and developed some abdominal complications and required partial colectomy. And so, oops, let's stay out of lower magnification. So this obviously is very abnormal mucosa here. And you can see the degree of change in the mucosa here. So you'd think of, as you look at this, is this an infectious process because they're immunosuppressed, or is this some other sort of related, drug-related change? Now we know that many of the currently widely used immunotherapy agents can produce a variety of inflammatory changes in the bowel. Most often they mimic microscopic colitis, but they really can take a variety of forms as well. And this patient was in fact not on any of those checkpoint inhibitors. So we can sort of cross that off the list. But she was on a number of antimetabolites, which obviously in this case were severely impacting the regenerative capacity of her bowel crypts. You see many of these crypts have shrunken and dropped out. And you have evidence of the cell breakdown in the form of hemosiderin in some of the stromal cells. So this I felt was a good example of chemotherapy-related colitis, and we signed it out as such, and that is just one of those complications that can occasionally occur with the use of anti-metabolite chemotherapy agents. I'm sorry, I don't remember which particular chemotherapy agent she was receiving at the time. It may have been, well, I won't even speculate because I don't recall. Okay, well, we have time for a few more here. All right, well, this was certainly a case that I learned a great deal from. This is a patient who had a pelvic mass, and they did a needle core biopsy of that. And I signed that out as a serous carcinoma, favor high grade. And that was because it was WT1 positive, but I don't remember what the P53 status was. Well, they gave her several interim courses of treatment. And then she came back with this persistent mass following treatment, and they had a cytoreductive surgery performed. So at low magnification, this is certainly not the usual pattern of a high-grade serous carcinoma, but it does illustrate, because we got a lot of stroma here, a relatively sparse amount of epithelium. And what we see here is this nice cribriform pattern of epithelium lining these spaces in several cases. We'll look and see a few other areas. So there's one area that's nice and cribriform. Here's another area here where you see this nice cribriform pattern. And so looking at these nuclei, you might think, well, these are not low-grade nuclei. They are a little bit higher grade than, say, the usual low-grade serous nuclei. And I think it may have been that nuclear grade which persuaded me on the biopsy to classify it as high grade. But in fact, this is the Cribriform variant of a low-grade serous carcinoma. And it shows up nicely through this lesion. And I had actually, I don't think I'd ever seen this before, or at least hadn't had a specimen to deal with. But here you can see the little bit of papillarity to it as well, with some reactive, more desmoplastic stroma around, which would be indicative of the invasion with this tumor. And I think there was some peritoneal spread of this lesion as well. So for me, this was a great learning case to see that, you know, not everything that has what might be considered higher grade nuclei is going to be high grade serous carcinoma when it's WT1 positive. And so keeping in mind this Cribriform variant, which can look a little bit like these arcades as you see here, would help us. Now, in theory, the P53 should have helped me here. And I believe that either the sample was sufficiently small that it was hard to tell, or we may have just had some other problem with interpretation at that point in time. But we routinely will do P53 stains on our ovarian tumors for this reason. And so recognizing and recalling this Cribriform variant that can look deceptively high grade is a good thing to keep in mind. Okay, let's come back to some frozen sections here. And here's a frozen section, I believe another soft tissue mass. Remind me of this case here. So as we look at this lesion, it has a very mesenchymal appearance. You can see there's a lot of cellularity here. There's not much epithelial type of differentiation, and quite high-grade cells. Let's go back out. Now, one of the challenges that we deal with frozen section is this artifact from freezing, where you can get ice crystals forming and so forth, that distorts the architecture of the tissue, and you can see that here in this lesion. We have a lot of myxoid tissue here. Well as a bubble. Let's go back here. Let's go the other way. So I'm not very good with this trackpad. Okay. So sometimes you have to kind of hunt around to find the diagnostic areas, as you can see that I'm doing here. So I believe that this case was a high-grade sarcoma based on the cytology here. And with the amount of myxoid tissue that we're seeing, we might well think that this fits fairly comfortably into the category of fibromyxoid sarcoma, or excuse me, Myxofibrosarcoma. This is a high-grade sarcoma. It used to be called myxoid MFH long ago in previous editions, and is a sarcoma to be treated with great care. In contrast to a term which is quite similar and can therefore be confusing, low-grade fibromyxoid sarcoma or myxosarcoma does not have a high-grade appearance. So Myxofibrosarcoma is a high-grade sarcoma. Fibromyxoid sarcoma is a low-grade sarcoma. You have difficulty with that sometimes determining that it's malignant. With Myxofibrosarcoma, it's quite obviously malignant. So I don't remember exactly what the question was they were asking us on this particular case, but I think you'll be able to study this and see the degree of pleomorphism that's involved. Now, in this circumstance, do we need to give the diagnosis of Myxofibrosarcoma? Not necessarily. If we're giving a frozen section diagnosis, telling them you have diagnostic tissue, it's a high-grade sarcoma, that's adequate for intraoperative evaluation. Okay, one more case here. So we're looking at needle biopsy here on a patient. Again, we're looking at being able to make a diagnosis so they can know kind of where to go with additional treatment. And this has a somewhat unusual pattern and architecture. We have this sort of lobularity to it with a lot of vessels. We have this intervening pale myxoid tissue, a little bit of collagenous tissue, and a lot of myxoid tissue here. So again, we're dealing with a myxoid lesion. Now we can look and see kind of what the degree of atypia is in this lesion. And I think we can appreciate that there's actually a fair amount of atypia in this lesion. Some rather large nuclei in this situation. Quite a vascular background for a myxoid lesion. So this is not just a simple myxoma by any means. And here we can see that the nuclei variable in size, quite large nuclei. We'll look at this more cellular fragment down here. Well, actually, this looks more cellular because it's more myxoid. So there's a very delicate vascular background here. And this again would fall into the category where we might think very seriously about Myxofibrosarcoma because of the myxoid pattern, the higher grade nuclei, and the prominent vasculature. Again, sometimes on a needle biopsy, you may not have or may not be able to get to all of the, to the specific diagnosis, but you can certainly give them the diagnosis of high-grade sarcoma, with myxoid features, and that would include, Myxofibrosarcoma, myxoid liposarcoma, things of that sort, that would all be treated fairly similarly in that initial situation. And that's if you don't have access to cytogenetics or fusion gene testing and things like that. That should be sufficient to guide the next stages of therapy, which usually will be probably maybe some form of radiation therapy followed by resection, or in some cases, other adjuvant, neoadjuvant treatments. All right, now I think I've got one last case here. Well, no, this is not the last case. I'll have to go quickly here. Okay, well, this is a small biopsy from a young child with a somewhat lytic lesion in the bone, and needle fragments, curetting fragments were obtained. And you can see here that we have a little bit of a sort of myxoid appearance to some of this, not quite chondroidish, but maybe a little bit chondroid or myxoid, and somewhat stellate appearing cells. A fair degree of atypia in some of them. A degree of cellularity here in some areas. And maybe some sense that there's a bit of matrix forming here. Here's a cell within a lacunae. And a fair degree of atypia to these cells. So a lytic lesion with some chondroid, and here osteoid type matrix in this fragment. This is not a challenging diagnosis per se, but sometimes one that we feel a little bit anxious about because we know the implications are very severe for a young child. So here's more of this kind of osteoid matrix. Unfortunately, with the digital slide, I can't do polarized light exam. But this is one situation where using polarization lenses on your microscope can very nicely illustrate the lamellar positivity to the osteoid. And we use that tool fairly frequently in osseous lesions to identify osteoid. So finding atypical cells like these amidst an osteoid matrix is the sine qua non of osteosarcoma. And this would be, have some chondroid differentiation, but it's not a low-grade tumor. This would lead to courses of chemotherapy, followed by hopefully resectability, and potentially now a much longer survival than might have been previously thought to be the case for these young patients. All right, one more case here. No, this is not. I'm going to skip to the last case here. This is the last case here. So this last slide is again from a younger patient. And this is on a distal extremity on their arm, and sort of a subcutaneous mass that has been sort of persistent and sort of irritated, maybe a little bit painful, and not really well defined. As you can see, when they biopsied it or tried to remove it, they thought it might be a cyst or something, but it just sort of came out in chunks. And as we look at it here, we can see that there's a bit of cellularity to this lesion. And some of these cells have just this very wild degree of cytologic atypia. So this is not a granuloma or something like that that we might otherwise think of with these epithelioid cells. It does have some inflammation around it and some fibrosis. So sometimes that's a temptation to think that this could be some sort of an inflammatory process. But really, as you look at these, there's certain nuclear pseudo-inclusions, irregular nuclear membranes. This looks much more atypical than any histiocytic lesion should look. Now, we might think about things like melanoma, because sometimes melanomas can have an epithelioid appearance and get pseudo-inclusions. This lesion would stain negatively with S100, but it would stain positively with cytokeratin, which sometimes is a confusing feature for many people. And you're probably nodding your head and saying, "Oh, I know what this is." But this is an example of epithelioid sarcoma. And epithelioid sarcoma can be positive with cytokeratins, positive with EMA, but most importantly, it's negative for INI1. INI1 is a marker gene within what's called the SWI/SWF category of genes that is indicative of a number of tumors. It's also known by SMARCB1, SMARCB1. And there may occasionally be other genes or other mutations, BRG1 and so forth, that might be involved with this, but conventionally, these are INI1 negative. Now, of course, there are a number of other tumors that are INI1 negative, but none of them in this clinical scenario would be pertinent. So rhabdoid tumor, other sorts of things like that, you wouldn't be thinking of in this setting. Now, why is this important? Well, it's important that this diagnosis not be missed or neglected because this disorder, if not adequately and fully treated initially, can become very progressive and very difficult to treat as it seems to spread more proximally. So, all right, well, we've gone a little bit over time. I'll just see if there's any questions people have. Sahar asks, how can we differentiate stroma ovarii from Leydig cell tumor of the pure cell type? So that's a good question. The answer to that, of course, would be primarily with immunohistochemistry. Now, both of them would have very uniform round nuclei, but stroma ovarii would have positive thyroid markers. And Leydig cell tumor would usually have sex-cord stromal markers like inhibin or calretinin, things like that, that would be completely negative in stroma ovarii. And question, is the papillary architecture affect the degree of endometrioid carcinoma? So I think in endometrioid type adenocarcinomas, there can be papillary architecture. It's usually more on the macro papillary feature, but there are actually some low-grade endometrioid carcinomas that can have a very micropapillary component. But the nuclei are very low grade. And so that, that feature, while helpful, papillary architecture, while helpful, it's not the diagnostic feature one way or the other, because both endometrioid carcinomas and serous carcinomas can have papillary architecture. The serous carcinomas with papillary architecture have very high grade nuclei. The endometrioid carcinomas with papillary architecture have uniformly low grade cytologic nuclear features. Very good question, very perceptive. Any other questions? Well, in that case, I just want to say thanks. It's been a pleasure to spend this time with you and appreciate your attendance. And we will see you next month. I'm going to have a guest professor next month.
Wait. Dr. Nasal, yes, I have two questions as well.
Okay.
So So from the very first case, are the criteria for follicular carcinoma of thyroid applicable in stroma ovary?
That's a very good question. And I have not ever had to deal with a follicular type carcinoma in stroma ovarii. And I'm not sure quite how you would define that, because capsular invasion is not going to apply in the ovary. So I think you'd almost have to be making that diagnosis based on molecular genetics or something of that sort, because I'm not sure how you would make that diagnosis in the ovary.
I see. One more question. I think the grade of endometrial carcinoma usually based on the squamous component. So do you usually give grades in the small biopsy or the accreditation specimen?
So you're correct. The amount of solid tumor is what forms the grading criteria for endometrioid carcinomas. We know that when we get a curettage or biopsy sample that we're just getting a small piece. And we have seen many cases where you have different grades in the final resection from a prior biopsy. We will usually give a grade in a biopsy sample, and sometimes we'll preface it by saying predicted grade 2 or predicted grade 1, recognizing that the ultimate grade could be higher. And the other caveat, of course, is that sometimes those higher grade areas are localized. And so that can be something that may not be seen on the surface of the lesion that gets sampled in the biopsy. So it's a good thing to keep your clinicians aware that they've just given you a small piece and the final grade could differ.
I also have a question.
Yes, Dr. Mary.
For endometrioid carcinoma, we have large amount of squamous differentiations, and then in biopsy specimen, and is there any IXC help in this case, like P16 or something that can help us to differentiate? Sometimes we will think about like adenoscomas or something in a small biopsy. So we got a case, and in fact it's not adenoscomas, it's just like endometrial carcinoma with a large amount of squamous differentiation. Yes.
Yeah, that is a very challenging area of grading when you have a lot of squamous morules or squamous differentiation. And in general, we don't use that. Obviously, we don't use the squamous component as part of the grading. And I think in the most recent WHO, we no longer have the category of adenosquamous carcinoma. So everything is pretty much either endometrioid or other type of tumor. But unless it's a primary squamous carcinoma, which rarely can occur in the endometrium. One thing that can be useful is that you can do a squamous marker like P63. And if you do that stain on the biopsy, you can then sort of subtract out those areas that are positive to determine how much other solid tissue is there. A lot of the differentiation, however, how should I say this? There's more and more acceptance of a 2-grade system for endometrioid tumors, low grade encompassing FIGO grade 1 and 2, and high grade encompassing FIGO 3. And in the most recent CAP cancer checklist, that is one of the subtext titles, is low grade versus high grade. And in reality, that really is what guides treatment. Now, there are some categories where they would call them intermediate risk. And in that situation, they might look at grade 2, things like depth of invasion, lymphovascular invasion, to determine whether they will give additional therapy and what kind of therapy. But that is usually done on the resection specimen, not on the biopsy sample. And so the grading that we provide on the biopsy really doesn't change therapy at that point. And so it's a nice academic effort, and it's helpful in that sense, but it's not going to strictly change anything in the management of the patient right away.
Yes, for our case, clinician mentioned that it is a tumor from the cervix, but first oncologist think that it is from endometrium. And when they just do the examination, and clinicians said that it is from the cervix.
Well, that's an important distinction too. And differentiating endometrioid from endocervix is a vitally important, because the surgery is different, the treatments are very different. And so in that situation, yeah, P16 stains and other materials to differentiate those two are very important to consider, because you can have combined adenosquamous in the cervix. And so if the squamous component is really malignant, that may be more likely that it's from the cervix.
Yeah. For our case, when we receive a surgical specimen, the squamous differentiation is not that much, just a small amount. And I don't understand why they can take the biopsy with the large amount of squamous differentiation. And in the cervix, there is nothing much. Thank you.
Okay. Well, it's always a challenge. So, well, any other questions? Thank you so much, everyone. And thank you for joining us. We'll see you next month.
Thank you.
Take care. Take care, Dr. Hassel. See you later. Yes.